Hello, I'm Tim Rooney, and we'll be talking today about radiology pathology correlation in regards to breast imaging. While this slide seems a bit tongue-in-cheek, and it is, it's really important to think about radiology pathology correlation throughout the process of breast imaging, from screening to diagnostic to consideration of biopsy to diagnosis to correlation and discussion with the patient. So just like we maintain our target of BI-RADS codes as we consider a breast patient, longitudinally staying on target throughout the process will be most important in this paradigm. As a thought of learning objectives, questions for mindfulness contemplation in regards to radiology and pathology correlation. First, are post-biopsy clip views important in 3D imaging in regards to concordance? Secondly, is concordance relevant in the male breast patient? If so, what things are not seen in the male breast patient? And we'll see this in regards to a case coming up within the lecture. Does biopsy device choice affect concordance? And I think we know the answer to that, but we always have to think about how that might be in the reality of a patient and following longitudinally. We'll discuss these in terms of cases, as I believe that cases probably best enable us to consider radiology and pathology correlation. This topic is particularly amenable to case presentation. The first case is a 45-year-old female who presents for a baseline screening mammogram. So we make certain assumptions about any female who presents for a baseline screening mammogram. Obviously, no comparisons are available. This is the first time we're seeing her. We assume that she's asymptomatic because she's a screening mammogram, and we have an intake sheet to confirm that from our technologist. The images with a digital, bilateral, MLO, and CC 2D mammogram are below. Take a minute to look at the images, think about the density, think about the technique and positioning, and then address the mammogram as you always would. If you make a decision, please answer the next question for me. What is the next best step in the diagnostic workup? And we'll present these cases with questions, seeing as this is the way that we consider our board's core exam currently. C is the correct answer. Diagnostic mammography and ultrasound of the right breast in the setting of a focal asymmetry. This diagnostic imaging was obtained for these purposes, 2D digital mammography technique. And you can see that there are spot compression views of the upper and outer right breast broadly at approximately 10 o'clock. And you have to ask yourself, what do these images show? These are additional images of ultrasound at the proposed area of concern. So what is the most appropriate BI-RADS code in this setting? In this case, BI-RADS 4 suspicious was selected with biopsy to be obtained. Based on the ultrasound images, an ultrasound guided biopsy was performed with marker placement at the site of biopsy. Although subtle, take a look at the marker and the breast and consider your own opinion in regards to RAD path correlation as we follow this through on this patient. The pathology returns as fibrosis and usual ductal hyperplasia. And I think we understand that fibrosis and usual ductal hyperplasia is a benign diagnosis by RADS 2. And the usual recommendation would be for annual screening. Obviously, in the context of this lecture, The important thing to consider is the radiology and the pathology concordant in this case? As you make your decision, another multiple choice question, considering the core exam, is given. Take a look and make your decision. In this case, not surprisingly, call the patient to discuss non-concordant results and recommend a tomosynthesis guided biopsy of the right breast distortion, which is persistent in the 2D imaging and certainly was in the 3D imaging. Concordance is critical, and this is the thing that we'll see throughout this lecture. It's very important to understand that our decision-making doesn't end when our biopsy is completed. It begins at the screening mammogram. What do we see when we're considering a callback or a BI-RADS 0? What do we see in a single view? What do we see in 2 views? What do we see on the digital mammography and possibly the 3D imaging? Concordance is again considered at the diagnostic workup. We're always taught in thinking about BI-RADS codes to think about the patient in a fresh perspective at each setting. So when she returns for her diagnostic additional views, concordance is again considered. What did we see on screening mammography? How will we work this up? And what modalities will we use? So we drive our differential considerations at the biopsy intervention as well as the diagnostic imaging. Concordance allows management and recommendations to proceed status post-biopsy. So when we talk to the patient with results, either in person or on the phone, we need to think about concordance throughout and how that will tailor our discussion with the patient in terms of recommendations for the plan, both follow-up and immediate management. Case number 2. A 49-year-old female presents for screening mammography. In this case, she's asymptomatic by definition because it's screening mammography. Immediately, we're going to think about concordance. This left CC and MLO 2D digital mammography is presented. Think about positioning, technique, and then possible findings. In this case, the screening mammogram was negative on the right. The left, as presented, became a BI-RADS 0. The radiologist decided to bring the patient back for additional diagnostic views for a focal asymmetry of the lateral left breast. This is perhaps 3 o'clock, it's perhaps 4 o'clock. The description might say how many centimeters from the nipple and the measurements of the focal asymmetry, given the BI-RADS definitions from the ACR BI-RADS manual. The subsequent diagnostic imaging was chosen as spot compression views, demonstrated in this case in 2 views of 2D digital mammography. 3D imaging may have been obtained. In this case, 2D imaging is shown both in the CC and orthogonal views. As you see, the focal asymmetry presents and persists in this generally low-density scattered breast. Your next decision is how further workup might be obtained, thinking about correlation as we go. And an ultrasound, not surprisingly, was obtained, where a small concordant in location, size, and imaging characteristics to present the dictation is obtained, showing a concordance from the diagnostic mammogram. This hypoechoic mass was decided to be a BI-RADS 4, suspicious, and an ultrasound guided biopsy was performed. So we have to think about what would be concordant pathology as we segue from the diagnostic imaging to the ultrasound guided biopsy. Obviously, we have the ultrasound guided biopsy at our disposal, and we know how the patient reacted during the biopsy, how many samples we made, where our marker placement was, and whether or not we were happy with the sampling. All those things go into the concordance equation. So, assuming all of this and our return from pathology, from our highly skilled pathology colleague, what would be concordant in this case? A fibroadenoma? Remember the patient's age, remember the original presentation, screening mammogram, return for diagnostic views, the diagnostic views we obtained, the ultrasound, and then thinking back on our actual biopsy technique in the room. Is a fibroadenoma concordant? I would say yes. In this patient population, assuming that we're seeing her in a screening paradigm, and we could, without the benefit of comparisons, not make too many decisions about relative growth, would a phylloides be possible? Given this size and these imaging characteristics, I would say less likely, but certainly in the differential diagnosis for concordance. Would invasive ductal carcinoma be in this differential? I would say yes. Sometimes a parallel mass may be seen with mildly irregular margins, which could represent invasive ductal carcinoma. In this case, this is concordant pathology if adequately sampled and comes back on pathology. Benign breast tissue? I would say no, and I hope you would agree. The idea here is that if benign breast tissue came back, did you adequately sample the area? Were you accurate? Did you get enough samples? And where was your marker placement? The final pathology returned, not surprisingly, as a fibroadenoma with annual screening mammography. Obviously, in our phone conversation, as we discuss concordance with the patient, we need to think about educating in terms of what a fibroadenoma is, its benign characteristics, and why we biopsied, and also why we do not need to do further special screening, but only annual screening mammography. Case number 3. This is a 70-year-old female for screening mammography, so by definition, she's asymptomatic. However, like many of our patients, comorbidities may limit their ability to be positioned or hold still for screening, and we need to be tuned in to those limitations. In this case, she had multiple comorbidities, and the imaging and the positioning and the technique were adequate, but limited secondary to these comorbidities. We have multiple years of her left breast digital mammography, CC and MLO screening views in this asymptomatic patient. Let's review them from left to right as we look at them from 2010 to 2017. Think about positioning, technique, and following findings within the breast over that longitudinal 7-year process. What would you select for your BI-RADS code in this screening mammography? Perhaps considered as a trick question, remembering that if we're seeing developing findings, there are 2 options, normal or abnormal from the screening mammography. In this case, additional evaluation BI-RADS 0. Remembering that a BI-RADS 3 and a BI-RADS 4 are not acceptable BI-RADS codes as we consider the screening patient. BI-RADS 2, however, is not correct in this juncture based on the fact that we are seeing evolving findings that need further diagnostic imaging. So when the diagnostic imaging was obtained and performed, we see spot compression views of the left breast, and we see a focal asymmetry identified in 2 views and persistent. In this case, I think the answer is obvious that we proceed to ultrasound. These 2 ultrasound images were obtained showing the distance from the nipple, showing the clock code, and then the radial and anti-radial, all as a standard part of quality assurance as we discuss and think about ultrasound images. In both of these images, we show an antiparallel hypoechoic mass with subtle peripheral vascularity and an irregular margin. From here, we consider a BI-RADS code based on our diagnostic imaging. In this case, which BI-RADS code would you suggest? BI-RADS 4, a suspicious mass. Biopsy is recommended. And I think you can understand why the rest of those are not appropriate based on various considerations of BI-RADS codes. A breast biopsy was performed, obviously, via ultrasound technique. You can see here on the pre-biopsy image, getting ready to sample this left breast mass. What would you accept for concordant pathology? Would you accept invasive ductal carcinoma? The answer in this case is yes. It would be appropriate and concordant to consider this in this developing finding, focal asymmetry which persists, somewhat suspicious on ultrasound, and comes back as invasive ductal carcinoma. Would you accept a papilloma? I would argue yes, you could accept a papilloma. She wouldn't necessarily have to be symptomatic. A papilloma in a postmenopausal patient may or may not have irregular borders, may or may not have vascularity, and could have this morphology and these findings on both mammography and on ultrasound. Mucinous carcinoma? Well, when we consider this and how it behaves in the setting of overall invasive ductal carcinoma, I would argue that yes, mucinous carcinoma could be part of the differential. While not essential that we consider subsets of invasive ductal carcinoma in our RAD-path correlation, this would certainly be within the realm of this lesion. Cyst wall and apocrine metaplasia. I would argue no. You would probably know this as you biopsy using ultrasound guidance, as unlikely. If this was a cyst, it would probably decompress. Many of the features, though, under ultrasound and under our diagnostic mammography, didn't support a cyst wall, and we might consider that we weren't accurate in our biopsy samples as we harken back to the actual biopsy procedure when we consider this. And so again, throughout the process, we think about RAD-path concordance. Why did I not include lymph node? Well, when you think about it, lymph nodes live in a certain area of the breast. This would not be common, perhaps in some specialized situations of reduction or prior procedure. And then I would also think about the shape, the margins, and how this presents in terms of its shape. However, even if we were considering lymph node, I'm not sure that I could accept that in regards to changing the BI-RADS code. It would be essential to sample this lesion before understanding or assuming this is a lymph node. So again, to think about concordance, it's built on the context of staying on target, as we discussed in the beginning of the lecture. The patient history, the personal family risk, all these go into our decision, from the screening to the diagnostic workup, the biopsy, and then the RAD-path correlation as we present results. Everything is considered in the context of risk, patient age, prior history. And so we're always thinking about that. So our imaging findings, our screening, our diagnostic mammography, whether it's 2D or 2D/3D, our ultrasound, and the MRI when we're utilizing it for specific MRI indications. The multiplicity and the bilaterality are always going to be important as we consider the screening examination, how they persist in the diagnostic examination, the considerations of prior biopsies, etc. And the device choice and the sampling confidence. As we know, different devices set up different levels of confidence based on our pathology report and how we're considering things. As we think about 3D imaging, we are biopsying subtle distortions. And as we biopsy those, whether on ultrasound, when concordant on ultrasound, or utilizing tomographic biopsy and guidance, we have to think about what that gauge device is, what our follow-up imaging might be to assure that we have thoroughly sampled that area, and our confidence subsequently. And of course, our pathology results, either as we read the pathology report or sometimes when we call the pathologists and talk about what they're seeing in terms of the size of the lesion, and sometimes in our RAD-Path correlation conference as we describe such things that are a bit more common in the world of tomosynthesis, certainly radial scar and complex sclerosing lesion. In our relationship with our breast cancer therapeutic team, all of us have different practice paradigms. Some of us are in academic institutions where we have close physical and conference-based relationships with our pathology colleagues. Some of us are removed in time and space with our radiology and our pathology colleagues and have to think more closely about how correlation will be followed up the breast surgery team and making sure that we communicate the plan with the patient and follow up with our colleagues. Next case. A 66-year-old female presents for screening mammography. Again, she's asymptomatic. Why? Because she's a screening examination. We see two right breast CC and MLO digital mammographic views. 2012 on the left and 2017 on the right. We know your patient is asymptomatic at this point. We're thinking differential diagnosis. And the reason we're thinking about this is because we're following through on our RAD-Path correlation throughout. While we're limited in our BI-RADS codes from a screening mammography, we're certainly thinking about how we're going to do the diagnostic workup. Differential diagnosis, invasive carcinoma, skin finding, do we have 3D mammography or do we not? Lymph node, fat necrosis, and we're thinking about that as our patient returns for diagnostic imaging. Diagnostic imaging was obtained in this case with spot compression and additional spot views, and an ultrasound was then obtained. The ultrasound demonstrates a subcutaneous, predominantly hyperechoic finding with internal vascularity and a hypoechoic center. It's arguably, somewhat parallel and immediately subcutaneous. The remainder of the breast tissue at this point appears normal. And then, of course, we're looking at the ultrasound imaging to ensure that our size, our location, centimeters from the nipple, and the persistence in the radial and antiradial view is appropriate for concordance as we consider this patient. How does this change your differential diagnosis? A purely hyperechoic nodule is, by definition, benign. Trauma to the site, fat necrosis, considering benign. Are there other findings in the breast in this case? Do we have path concordance, and what would we consider for path concordance? Would invasive carcinoma be appropriate here? As I mentioned, there is a hypoechoic center, which may be consistent with fat necrosis, but a purely hyperechoic nodule is not seen in this case, and therefore invasive carcinoma could be a consideration, and sometimes biopsy is important to consider when we don't have a purely hyperechoic nodule and we need to consider RAD-path correlation before determining its benignity. Will a lipoma be appropriate here? Probably not. A lipoma usually doesn't have such irregular edges. It usually has a more uniform internal increased echogenicity. And I would say in this case, the relative vascularity, the hypoechoic center, and the irregular edges would probably decrease the likelihood of a lipoma significantly. Fat necrosis. I certainly think that this has imaging characteristics consistent with fat necrosis. It's a new, subtle finding. It's difficult to see in all views. And then the ultrasound characteristics are fairly consistent with fat necrosis. And this would be in your differential diagnosis for RAD-path concordance. How about benign breast tissue? And the reason I would say no is, again, we have to make sure that we see the lesion. If we have purely benign breast tissue, we have to consider, have we adequately biopsied and assessed this lesion? So, again, when we think about concordance, we think about real-time assessment of biopsy samples. And I always counsel my residents that the first is the money, biopsy. The first is the most important, the first biopsy. Why is that? It's always possible that we have a patient that reacts with pain, that we have a patient who has unexpected bleeding, and we only get one biopsy sample. While that's very rare, it can happen, and so it's important to always line up our first biopsy and to do our best work at the first biopsy sample. We think about adequate samples in general, assuming the patient's tolerating the entire biopsy procedure to demonstrate the possible pathologies. And we always do a post-biopsy mammographic view when able to determine clip marker concordance with biopsy location. Occasionally for bleeding or other logistical reasons we can't, but that's suboptimal. And I try to do this in 100% of my patients where it's appropriate. There are certain reasons, either a very young patient or the marker clip would be out of the field of view of a mammogram, or bleeding was significant and could be restarted with a mammogram, where we might want to delay it. But we want to get it as much as we possibly can. Do the pathology findings fit the clinical and imaging scenario? And again, thinking about our patient from start to finish longitudinally. Next case. Case number 5. A 51-year-old male with left breast mass. So, as discussed in the first or second slide of the presentation, it's really important to think about how males present their age groups and RAD-path correlation in the fact that the lobules are not developed as they are in a female, assuming a male hormonal background. Presented is a bilateral MLO and CC view, digital mammography in a 2D digital format, thinking about positioning, pectoralis, the density of the breast, and the finding. What is your next step in management? Would you biopsy? Would you do an ultrasound? Or would you just ask for clinical follow-up for the etiology for gynecomastia? In this case, based on the findings themselves and the location of the findings, an ultrasound was obtained. As you can see, there is a chest wall, subcutaneous elements, and normal skin with a subtle hypoechoic finding at this location, which was concordant in location, size, and imaging characteristics from the diagnostic mammography. Differential considerations include the above. An ultrasound guided biopsy was performed and marker clip placement views were obtained showing the clip inside the lesion. Would you accept gynecomastia as concordant pathology? I would say no, based on location, based on the imaging features, the fact that the ultrasound was done, and although gynecomastia is not often visualized or considered as a breast ultrasound finding, in this finding I would say this does not look like gynecomastia on ultrasound. Would you accept invasive ductal carcinoma? I would say yes, based on the nonspecific findings, the location in a male, and the fact that the ultrasound findings were somewhat nonspecific. Would you accept a fibroadenoma? I would say unlikely, based on the fact that fibroadenomas are a lobular finding, and lobules do not really proliferate in the male patient with the male hormonal background. Invasive lobular carcinoma, similarly, statistically would be very unusual. Zebra, in this case, yes. The final path diagnosis is interesting, unusual, as a hemangioma. So what would your recommendation to be? Again, we're thinking about radiology and pathology correlation. Just remember that one of the final steps of this process is your call, your discussion with the patient, and what are the next steps? Would you recommend any of the above? In fact, D is the correct choice for re-excision to include angiosarcoma. Again, a zebra, exceedingly rare, but important to demonstrate things that we have to think about as we longitudinally follow the patient from start to finish for RAD path correlation. Is the 3D post-clip views helpful in regards to concordance? We asked this at the beginning, and I would say certainly very helpful as we think about 3D only findings with our current mammographic tomosynthesis availability. Is concordance relevant in the male patient? And if so, what diagnoses are not seen in the male patient? And I think we've already discussed this. One has to consider etiologies in context of the male hormonal milieu and the fact that lobular pathology is exceedingly unlikely. But does biopsy device choice affect concordance? And I think we know the answer to that. In some cases, we utilize a vacuum technique in ultrasound guided biopsy with a subtle lesion or a consideration of a vascular papilloma. And then we think about tomosynthesis guided technique in the setting of a distortion. So you always need to consider how you best see something and think about patient ease and comfort. Where it used to be that ultrasound was almost always the answer, this is not necessarily the case with the advanced tomosynthesis guided biopsy technique that we now enjoy. Thank you very much. I hope that you've enjoyed this. We utilize the case format to consider the radiology pathology concordance, thinking from the screening examination through the diagnostic workup and imaging, through the decision to biopsy, and then receiving those biopsy results and thinking through our discussion with our patient as we consider our decisions with our breast cancer patient throughout the process.